Hi everyone, our subject today is back pain in pediatrics. Any condition causing pain of the thoracic, lumbar, or sacral spine. Back pain is uncommon in children, especially chronic or severe back pain. Most children who complain of back pain have mild, self-resolving symptoms of limited duration. Symptoms of severe or persistent back pain, as well as any abnormal finding on physical examination, mandate a thorough evaluation. The history should inquire about trauma, associated leg pain, gait abnormality, weakness, extremity pain, or tingling, bowel or bladder incontinence, and any systemic sign or symptoms, fever, malaise, rash, GIT symptoms. Also, ask about aggravating or relieving factors, particularly whether it is relieved with rest, and whether it wakes the patient from sleep. The physical examination should include careful neurological and abdominal examination, as well as a complete musculoskeletal examination. The neurological exam should include assessment of the anal tone, and in male, the cremasteric reflex. A pelvic exam may be indicated in older adolescent females. How to approach child with back pain after performing history and physical examination. It is acute. If it is acute, ask about fever, systemic illness, if it is present. If it is yes, perform complete blood count with differential, C-reactive protein, ESR, consider MRI and other radiological or lab testing like urine analysis, amylase, lipase, based on clinical findings. Differential diagnosis, discitis, leukemia, neuroblastoma, or other primary or metastatic tumor, referred pain like pyelonephritis, pancreatitis, nephrolithiasis, pneumonia, constipation, appendicitis, abscess, vertebral osteomyelitis. If there is acute and no systemic illness present, perform X-ray. If it is abnormal, this is fracture, accidental or non-accidental child abuse. If it is normal X-ray, consider repeat X-ray in 2 weeks versus MRI or bone scan. If it is abnormal, as we mentioned, fracture. If it is normal, differential diagnosis, contusion, abrasion, muscle strain, ligament sprain, mimicry, recent lumbar puncture, seatbelt injury, somatoform disorder. If the back pain is prolonged or recurrent, you should examine the neurological system for neurological deficit. If it is present, perform MRI. If it is normal, this is conversion reaction. If it is abnormal, differential diagnosis, primary spinal or vertebral tumor, astrocytoma, osteogenic sarcoma, osteoblastoma, metastatic tumor, leukemia, neuroblastoma, lymphoma, transverse myelitis, epidural abscess or hematoma, spondylolisthesis. If there is no neurological deficit but prolonged or recurrent back pain, perform X-ray with or without MRI or bone scan. If it is abnormal result, differential diagnosis, spondylolysis, spondylolisthesis, spinal deformity, kyphosis, Sherman disease, scoliosis, severe disease, ankylosing spondylitis, vertebral osteomyelitis, Pott's disease, leukemia, other metastatic tumor, benign bone tumor, discitis, bone cyst, hip or pelvic anomaly, herniated disc, or juvenile osteoporosis. If it is a normal X-ray or bone scan, consider additional workup specific to associated symptom. Of course, if there is no neurological deficit and normal X-ray, differential diagnosis, overuse syndrome, rheumatological disorder, juvenile idiopathic arthritis, ankylosing spondylitis, other spondyloarthritis associated with inflammatory bowel disease, psoriasis, or post-infectious. ulcerative colitis, fibromyalgia, sickle cell disease, hematocolbus, and upper cervical spine instability. Red flag. A school bag that exceeds 10% of body weight can lead to back pain and later become chronic. Back pain in association with fever and focal tenderness raises the possibility of serious pathology. Persistent and localized back pain that is worse at night may suggest either a benign cause like osteoid osteoma or bone cyst, or a malignant neoplasm, Ewing sarcoma, lymphoma, or neuroblastoma. Be aware of the high incidence of uveitis in suspected cases of ankylosing spondylitis. Alert! Warning sign of potentially serious cause of back pain in children include young age, less than 4 years of age, duration of pain more than 3 weeks, chronic interference with the normal activity like school, sport, play, associated fever, weight loss, or other systemic symptom, postural shift of trunk, neurological abnormality, limitation of spinal motion like bending forward, straight leg rise, back pain associated with bowel or bladder deficit, gait abnormality, lower extremity pain, weakness or reflex or sensation deficit is suggestive of space-occupying lesion, spinal cord tumor, metastatic lesion, and warrant urgent evaluation. Consider a urine pregnancy test in adolescent females prior to obtain X-ray. The presence of associated abdominal pain, vomiting, dysuria, hematuria, or vaginal complaints should prompt a specific evaluation for intra-abdominal or pelvic problems. Discitis is an infection or inflammation of an intervertebral disc space. The most common pathogen is Staphylococcus aureus. Children younger than age 7 years are most commonly affected. The peak incidence is 3 years. Common clinical findings are back pain, limping, and shift stride posture due to loss of normal lumbar lordosis. Younger children, 3 years of age, are more likely to be present with a toxic picture of fever, refusal to walk, irritability, and decreased appetite. MRI is preferred in early presentation because it will better differentiate condition with the similarity, vertebral osteomyelitis or abscess. Spinal X-ray or bone scan may suggest the extent of metastatic tumor involvement in the spine, but MRI will be necessary for more specific definition of the disease process. CT scan may be preferred when the pathologic fracture are suspected because of better bony detail. Intra-abdominal, retroperitoneal, or pelvic processes can cause referred back pain. More specific signs and symptoms should aid in the diagnosis of problems such as pyelonephritis, pancreatitis, nephrolithiasis, and abscess. Primary vertebral osteomyelitis is rare in young children. It typically occurs in children older than 8 years, and insidious onset is more likely than an acute toxic presentation. Presentation commonly include a vague or dull backache that may be worse at night. Pott's disease is a tuberculosis spondylitis, a rare complication of untreated tuberculosis that is more likely to occur in children than adults. If pain persists, consider repeating X-ray versus obtaining other imaging in 2 weeks. Callus formation may indicate fracture not obvious on initial films. In cases of suspected child abuse, a bone scan should be considered early in the evaluation when initial X-rays are negative. Continuous and contusion and abrasion are the most common back injuries sustained in routine play and sport in young children. No additional workup is needed. Spondylolysis is a defect stress fracture of the bony connection between vertebral body and its arch, pars interarticularis. Spondylolisthesis is the forward spillage of or displacement of one vertebra in relation to another. Classic spondylolisthesis in children and adolescents involve the fifth lumbar and first sacral vertebral bodies. Symptoms vary based on degree of subsequent nerve compression. Children participating in sport involving repetitive flexion and hyperextension, gymnastic, football players, weightlifter, are at increased risk for spondylolysis. Symptoms: poorly localized lumbar and lumbosacral pain, hamstring tightness, often do not occur until the adolescent growth spurt. Spinal hyperextension typically exacerbate the pain. Defects often remain asymptomatic indefinitely. When symptoms do occur, they are not always consistent with the sensitivity of the spondylolytic defect or the degree of the slippage. Kyphosis is an aggregation of the normal thoracic or thoracolumbar curve in the sagittal plane. In postural or flexible cases, it is fully correctable with a voluntary effort, and any associated pain is typically mild. Spinal films should be obtained in severe cases and when significant back pain is present to rule out Sherman disease. This is a structural hyperkyphosis. X-ray will show vertebral end plate irregularities and vertebral bony wedging. Most cases of scoliosis, regardless of the age at onset, are idiopathic. Idiopathic scoliosis is not painful during childhood and adolescence. If pain is noted with the scoliotic curve, careful consider infectious, inflammatory, and neoplastic causes. Benign tumors of the spine are rare. The most common ones are osteoid osteoma, osteoblastoma, and eosinophilic granuloma. Presentation is typically a prolonged period of back pain, especially at night, that eventually evolves to stiffness and rarely a painful scoliotic or mild neurological deficit. Overuse syndrome are more common in athletic adolescents than younger children. The stress of the normal physiological activity results in microtrauma, which typically resolve. Overuse injury results when repetitive activity without adequate conditioning or rest prohibits this resolution. Both bone and soft tissue, muscles, tendons, brusa, cartilage are susceptible to overuse injury. Gymnastic, dancer, weightlifter, and football player are particularly prone to overuse injury of the backs. Thank you for your listening.